We're going to do acquired newborn complications now, so I may combine it along with the high risk. We'll see. I think I can get them both on the same. Alrighty. Acquired problems in the newborn is going to relate back to some of your labor and birth complications of the mom. So they kind of go hand in hand. Remember we talked about forceps and vacuum extraction delivery. Forceps delivery here looks like tongs that are salad tongs. You can see where there's one on this side, there's one on the other side of the baby's head, and the baby is being pulled out. This baby's a lot higher up in the birth canal than the one using the vacuum extractor. If you can use the vacuum extractors, most doctors do. Using forceps when you go inside and go to either side wall of the vagina, a vaginal wall can be damaged and you may see hematomas form. So if you have a forceps delivery, you should monitor your mama for vaginal hematomas. With this type of delivery, we can see damage to the eye if the forceps aren't placed correctly. We can see damage to the ear, and we can see lacerations on the chest. With our vacuum extractor, where we're pulling on the scalp with vacuum here, you're going to see a caput succedatum, or you're going to see a cephalohematoma. So you need to monitor for both. A caput does not cross the suture line, whereas a cephalohematoma does. So cephalahematomas take longer to resolve because all the blood breakdown has to occur because they're full of blood, and it can also cause jaundice in the infant. So those are some things you need to watch for. Um, the caput will usually resolve in a day or so. Then you remember we talked about brachial plexi, and I showed you the picture of the baby with his little arm stretched out. Well, this is one that has the brachial plexi as well, and look how damaged his poor little arm is. Here it shows you the plexus being stretched because we're trying to get this baby out, and he's got some shoulder dystocia going on. So you really have to manage the delivery of the baby when the shoulder dystocia is there, because you can cause brachial plexi to occur. And I've seen a lot of lawsuits being given to the moms because of this damage that's done. Okay, so physical injury acquired during birth is what our acquired newborn injuries are. We talked about the bruising. If they have bruising, it could be because they had a rapid delivery, or they may have had a facial presentation. Although very few babies deliver a face presentation, they go through quite a bit of labor before determining they have a face presentation. Lacerations can be caused vaginally by the forceps, or they can be caused cesarean by the suturing, or not suturing, but the cutting blade. So clavicle fracture is one of your most common bones that's broken, and usually that's from either the baby being so big that the clavicle fractures on its own, or that the doctor fractures the clavicle to get the shoulders out. Sometimes you'll see facial paralysis after the use of forceps. It usually will resolve itself. And then the subdural hematomas are really kind of bad. You can get intracranial bleeding from this and have some pressure going on, especially with your preterms. Our neonates of our diabetic moms, gestational versus the insulin dependent. Hyperinsulinemia is a big issue with both. The larger gestational age belongs to the gestational mom most of the time. Assess for respiratory distress on both, because the babies of diabetics mothers and gestational diabetic mothers do not develop their lungs. The surfactant doesn't develop as quickly in those babies. Always assess these babies of these two types of diabetic mothers for hypoglycemia, because once the cord's cut, all their supply of sugar is gone, and they may have developed more insulin, so they develop hyperinsulinemia, and they have to have more sugar in order to support that. The macrosomia baby, that's a baby with big head, big shoulders, and they're really spongy. I hope that you'll get to see a true diabetic macrosomia baby, because they just look different. They're like a pudgy marshmallow man. Okay, we have neonatal infections, we have sepsis, septicemia, septic shock. We have different types of things that go on with the neonatal infections. And basically, the worst ones are the ones that they acquire in utero. Because that means when they're born they have already been sick for a while. And sometimes, like the cytomegalovirus, mom can present with flu-like symptoms, and then it just goes away, and she just chalks it off to a cold, and then the baby is going to contract this virus, and it becomes a cytomegalovirus. So, and this is a pretty nasty virus for babies to have. Torch is just a shortened version of toxoplasmosis, other infections, rubella, cytomegalovirus, and herpes simplex. What you need to know about the toxoplasmosis, basically that is what used to be known as cat scratch fever. And so that usually occurs like when they're changing their cat's litter box. So if they have a cat, they need to not be changing the litter box to decrease their exposure to this. Rubella, of course, is not a very good disease for them to contract. If they do get congenital rubella from being exposed while they're in utero, the risk is going to actually vary with the gestational age when the infection occurs. If she contracts it in the very first trimester, during that 1 to 8 weeks is highly developmental stage, the sequelae is really severe. You'll see cataracts, glaucoma, cardiac defects, a lot of different hypotonia, maybe hepatomegalia. So you really want to be watchful for that. One thing about if you have a baby that's born of a mom that had rubella during her pregnancy, you have to isolate the baby in the isolation nursery, or keep it in the mom's room and not take it to the nursery, because they can shed the virus for up to 18 months after birth, which means that they can, if they're shedding the virus, it can be spread from them to others in that 18 months. So they have extended pediatric isolation until they actually aren't shedding any more of that virus. So that one can get to be pretty rough there. The cytomegalovirus, they have a really bad rash all over their little face. They can have seizures, lethargy, hypotonia, thrombocytopenia. It's just a pretty bad little thing for these babies to have. Your herpes simplex is, of course, if they have an open lesion and they have active herpes, they should be sectioned instead of vag delivery. Vag deliveries, the baby comes through the birth canal, and if there are open lesions or active lesions there, then they are exposed to the herpes simplex virus. If the water breaks and they have active lesions, then the virus can actually go up through the amniotic fluid and ascend, so you can have an ascending that. It's really pretty. You know, when you do see it, they'll usually present with some type of lesion that you recognize, and so be sure that you are wearing your gloves anytime your baby has any kind of lesion or anything on them. So be sure that you're wearing your gloves. Um, with our septicemia, we usually try to catch that early on. It's usually something that they have developed via some kind of infection mama has contracted, and sometimes the earlier you deliver these babies, the better chance that they have. So these are all things that the septicemia and the sepsis all need to be started immediately on their antibiotics, and the culture be done so before antibiotics are started, so we'll know which antibiotic we really need to be using. We have gonorrhea that causes them to have eye infections. They treat that with erythromycin ointment. Syphilis, if transmitted through the mother, they can develop congenital syphilis, and they need to be treated for that right away. Moms need to understand that if they get syphilis, they get treated for syphilis, that they can get syphilis again if they go back to the same source where they got syphilis. And if they if they get treated and they get rid of the syphilis, the baby gets treated at the same time. But if they come in and they are active again with syphilis, then the baby is going to be born with syphilis. And so we have to be very careful with good hand washing, making sure we are wearing our gloves, and monitoring. Usually, there's a picture in your book with a baby's foot that has syphilis lesions on the bottom of their foot, and it's pretty awful. HIV is not as bad as it used to be. Sometimes they'll test positive when they're not. We give mom medication during labor, and then as soon as mom delivers, the baby gets started on medication as well. And we have seen a drastic decrease in HIV neonates, which is awesome that we would see that. We already talked about rubella. Hepatitis B, mom gets it and it's transferred to the baby, and we need to give the baby a hepatitis B shot along with an H-big immunoglobulin shot to prevent the baby from developing any further. If it's all babies get the hepatitis vaccine, but babies that are born with hepatitis B positive moms gets the H big as well to try to keep it in check. We talked about the cytomegalovirus and the herpes simplex virus. We've talked about it yet, so we can hop on to the next one. Then we have those bacterial infections. You all should be familiar with the group B. We treat mom so that it treats the baby. We're not treating mom to treat her symptoms. We're treating mom to treat the baby, to prevent problems with the baby developing group B strep. And they may still very well develop group B strep. So we really monitor these babies and keep them usually for 48 hours. Tuberculosis, if mom has tuberculosis, she needs to have, if she has active tuberculosis, she has to be treated successfully and test negative before she can breastfeed. If she's testing positive, she can't breastfeed. Babies can develop tuberculosis, but we don't see a lot of that. Listeriosis is kind of from animal diseases, so we got to we see that going on. And then, of course, your fungal infections are your yeast infections that you can treat with nystatin. So there's different types of drugs, of course, that affect the baby, and we've already talked about some of the drugs. So alcohol, you get the fetal alcohol syndrome. Heroin, they have a little bit of withdrawal from it, but they should be taking methadone, and they will not have withdrawal from methadone. Well, they do have withdrawal from methadone, but they need to be taken off either of these drugs slowly. They should never be stopped during pregnancy. The heroin should be switched over to methadone, and then after baby's birth, we'll have to gradually get the baby off of the methadone. Marijuana tends to cause a few developmental delays, maybe some memory problems. There really hasn't been enough studies done on that. Cocaine, they don't have actually withdrawal like they do with the narcotics. but they do have some, they present with shrill cry and being irritable. So all babies that are born with, to moms that are alcoholics or heroin addicts or whatever they are, should be provided a quiet room to be in. They should not be in a room that's full of noise in a well-lit, or they should be put in a quiet nursery. A lot of times babies, especially preterm babies, develop environmental stress syndrome, where they're put in these cribs or in the isolettes, but there's always a lot of noise in the nursery, such as the oxygen running, the suction running, people opening and closing the doors to their cribs. The cribs get bumped, people lay things on top of them, they just chunk them on top. So a lot of times they don't sleep well, and it's usually due to that environmental stress syndrome. So you need to watch out for that. You've heard me talk about neonatal abstinence syndrome before. This happens whenever you have a baby that has been just cut off cold turkey from his mama's drug of choice. Also will occur if you give Narcan to the baby if you think that they're just suppressed because of drugs. If mom's been doing them for a while, you'll cause the baby to go into neonatal abstinence syndrome. So you don't want to give Narcan to any baby of a drug addicted mother. Of course, it's hard to know if they're a drug addicted mom because they don't want to own up to being um, a drug user. Then we have our hemolytic disorders. Y'all have been exposed to hyperbilirubinemia. As is any time that their level goes over 12 milligrams per deciliter is your cutoff as far as that is your high norm. You can have physiological jaundice, pathological jaundice. You can even have breastfeeding jaundice. You can have Rh incompatibility, ABO incompatibility, and then kernicterus, which is a jump off of the bilirubin. This is when your bili levels get up over 25 milligrams per deciliter. And this is very dangerous. It causes a lot of sequelae in the baby. Brain damage is really severe, and about 50% of your babies that develop kernicterus will die. Your physiological jaundice is caused by things that are physical, such as they're not taking in enough nutrients to wash out the bilirubin that the body's breaking down the red blood cells, and the bilirubin is part of that breakdown, and it is put over into the skin if it's not able to pass through the liver, because the liver's immature at this time. If they're not taking in enough nutrients, then it's not passing out of the body, so the baby starts getting yellow or jaundice, and that's physiological jaundice. It's caused by something physical that's happening that we can correct. If it gets over 12, we still put them under the Billy light, eye mask, making sure they're nude all the way down to their diaper, turn often, take temperature often, protect their little bottoms. Pathological jaundice, on the other hand, is when you start seeing jaundice before the age of 24 hours. Anytime you see a baby that has a jaundice color to them, several hours old up to 24 hours, they should not be looking jaundice. And if they are, we need to see if there might be some type of hepatic involvement, some atresias, something that's causing the baby to have a high bilirubin at before 24 hours. So you want to be sure and call the doctor if your baby is jaundice, notably jaundice before 24 hours of age. Rh incompatibility occurs when you forget to give the RhoGAM after an Rh mom delivers an Rh positive baby, or if she's had a miscarriage and doesn't even know she had a miscarriage. Antibodies can form and make it the next pregnancy very complicated for the baby, and they can develop a lot of sequelae from having the hemolytic disorders. Then usually you will see Erythroblastosis fetalis is what it's called, or hydrops fetalis. That's a severe form that develops from Rh incompatibility. Baby gets the fetus gets real edematous inside, gets extremely anemic, and there is a possibility of doing intrauterine transfusion through the umbilical cord if they see that they need that, but usually um, the babies that have developed the erythroblastosis, which is the most severe form, is going to be not be a viable baby. It usually has an intrauterine or real early neonatal death. And usually with this, if you see this Rh incompatibility is going to result in that them having marked anemia, fetal anemia. So the type of type of pattern you would see, because this is an anemic type disorder, you would see a sinusoidal pattern, same as you would with an abruptio placenta. That's going to cause the baby to be anemic. You may see a sinusoidal pattern. Then your ABO incompatibility is going to be one of our most common one. That's where mom is O, type O, and baby is either A, B, or A or B. So if mom's O blood makes antibodies against the A and the B blood, so that there are issues that can go across, these little antibodies can cross the placenta, and then these newborns usually will have a positive Coombs, and we'll be checking the bilirubin on them. Usually these babies go under the Billy light and stay under it for a little while. We can do exchange transfusion, but we only do that if we have to do that. So, kernicterus causes can cause acute bilirubin encephalopathy. And again, this is the one that your bilirubin level is 25 milligrams per deciliter. It can cause some severe problems. Like I said, only 50% of these babies survive. And then, of course, our little congenital anomalies are present at birth. They're caused by some type of environmental or genetic factor in that first trimester. Cardiovascular ones we are going to talk about when we talk about cardiac pediatrics. So I'm not going to really go in depth about those anomalies. Just remember, these all occur in that first 8 weeks. And with the cardiovascular one, it's the usually the first 4 weeks when the heart is beginning to form and starting to beat. But other than that, I'm not going to have you look at all the different heart defects, because we're going to be looking at those in cardiac pediatrics. Most of our central nervous systems are caused from neural tube defects. Neural tube defects can be prevented by taking folic acid before you become pregnant and during pregnancy. Excuse me. So there's a lot of even excessive heat in the very first trimester can actually cause them to have an increased risk of neural tube defects. So you don't want to tell them to get in the hot tub to relax if they're having back pain, because they don't want to get too hot. Encephaly, encephalocele, and encephaly. Encephaly is when they're born without a brain. These babies don't survive. They may survive long enough for a few days, but they don't survive because they have no function other than to eat and maybe breathe. The encephalocele is a herniation of the brain, and you'll sometimes see that happening. The myomeningeocele is when there is a protrusion of the spinal cord or fluid on the back. A dimple on the back can indicate there may be an occult spina bifida there. Main thing that nurses are responsible for doing is to make sure to cover it, to protect it, lay them on their tummies instead of on their backs. They can develop latex allergies because they're so exposed. You want to try to be sure to use latex free as much as you can. I think Miss Candler goes over the hydrocephaly with you guys and the microcephaly, and I'm not going to get too excited about that. She also goes over congenital uh, diaphragmatic hernia. That is just where the diaphragm has not completely sealed and the intestines go up into the thoracic cavity, and if we bag these babies when they're born, it causes air in the tummy, which pushes the intestines up into the diaphragm even more, causing them to be unable to expand what little lung they have managed to develop there. So it depends on how much intestine is in that thoracic cavity as to whether they can survive or not. Also, Ms. Candler went over your cleft lips, went over your atresias, gastroschisis. We have gone over for the musculoskeletal, we've gone over the hip dysplasia, so I'm not going to go over that again. You should know that by now. Genitourinary, if you can't identify if it's a male or female, you may have to wait until the baby develops a little bit more, or there may have to do some ultrasounds to determine what inside um, reproductive organs are in there. Um, Hypospadias, of course, is when the meatus is located at the top of the penis, and epispadias is just when uh, the urethral doesn't canalize on a male baby. So, then we have our genetic disorders. Uh, this is the test that we do at the end of the day, or when the baby's fixing to go home. We have to wait at least 24 hours past ingestion of milk or breast milk to see if these genetic disorders exist. If they haven't ingested enough milk, the test is going to be negative because there's not been enough ingestion of the product to cause the inborn error to show. So this is usually a metabolic defect that results from the absence or change in a protein. And then phenylketonuria is one of the major ones that we test for. Galactosemia, congenital hypothyroidism. Um, these are the major ones that are required by all states. And we put this on the piece of paper we put our blood drops on is called a Guthrie test. So we test for that with the Guthrie test. And these are a genetic inborn error of metabolism. Remember we talked about with the PKU that if mom had PKU, she would have to go back on her PKU diet before she became pregnant during pregnancy, because chances are her baby would develop phenylketonuria. So um, that's why it's very important for us to document the first time the baby feeds and then try to do the um, Guthrie test at least 24 hours after that. Although the state is requiring now that we get that test done as soon as possible, because a lot of babies are still going home without having it done. But if they might as well go home without having it done if they're not getting it done during a period of time that they need to.